Speaker for the next topic, critical care update in neurology is Dr. Debashis Dhar, Senior Consultant Critical Care, Sir Gangaram Hospital, New Delhi.
Good afternoon, respected chairpersons and my friends. I at the outset thank Dr. Kishore, Dr. Deepak and Dr. Ravi for inviting me and giving me this opportunity. And before going to the neurocritical care update, I just wanted you to update about the cricket score. That India is in a very sound position. And they are now, so fifth wicket is down 152 for 5. Okay, so you should not miss the fun because 50% of the people have left. They are having fun, so why you should miss the fun? Isn't it? You should have pleasure drive. So coming to the neurocritical care update. In this update, I have tried to include in the last 1.5 years what all has been literature which has been published. I have gone through them, I mean not all of them, whatever I could get through, and try to include only those aspects which are affecting our day-to-day critical care update, critical care management. So neurocritical care, why does it make a difference? This was the current critical care opinion in 2014, they published this. Does it really make a difference? If you see, I am just jokingly telling, in the today's update, when you have started in the morning, started with respiratory care, hemodynamic monitoring, your fluid therapy, etc., etc. And at the end, neurocritical care, and last is the feeding, the gastroenterology, isn't it? And actually that is what happens in the majority of the time in the ICU. When any patient comes, we are more bothered about trickling with the ventilators, setting the modes, how much PEEP, how much fat fluid to be given, isn't it? What is the blood pressure, mean arterial pressure, and etc., etc. And we usually don't see the patient completely, isn't it? And it's important, I am not denying it, because initial resuscitation is the most important thing. And as you know why it is important is the fact that if you don't do initially resuscitate, unless until your patient is a primary neural trauma patient or neurological patient, the secondary brain injury is the commonest thing which happens to this patient. And to prevent that secondary injury, you have to have a proper resuscitation in this patient. And as Sir was emphasizing about the pre-hospital management, so this is to prevent the secondary injuries. So in this update, what they found that if you, they have done a study of around 40,000 patients, cohort studies, and this is the total meta-analysis of 24,000 patients. What they found that when the patients are taken care of by ICUs where they have a proper neurocritical care protocols, the outcome and the mortality benefit is definitely there. So it is very important to have a neurocritical care update. Otherwise, your patient may survive, but they will be vegetable. So your resource what you have utilized will be of no use to the nation. And why it is so? Because once you have a proper training and knowledge of neurocritical care, it has been seen that the secondary brain injury insults, how to detect them, how to treat them, is always done in a much earlier, otherwise in a critical care setting where it is not there. So it is important that we should have the proper neurocritical care team and the knowledge. The one thing which has happened, they say, you are all using Glasgow's Coma Scale. This is one of the standard care since last 40 years. Isn't it? Because it was since described first in 1974 by T.S. Dell. Now these 40 years onward, this is one of the things which has been cited in more than 45,000 times. and it is the standard of care as per WHO is concerned in the trauma classification, and this has been translated in all the languages in the world, and it is used in more than 80 countries. But what they found when they reviewed it over last 40 years, they found there is lots of variation in the practice and abstractness and ambiguity here. And so this is what they have changed, and they have proposed how to go about the Glasgow coma scale, which we all do it, isn't it? Whether in the pre-hospital, in the casualty, in the ICU every day. So we have know that you already know this, spontaneous, to sprain, this. So how to quantify it? You say to speech, what is the speech? So these things are very abstract things, and that is why they have come out with this this recommendation by the same Glasgow Institute of Neurological Sciences, that how to you score the patients. Oh, sorry, it's ulta ho gaya. Sorry. This is what. So if you see that, if your patient means, when you say it is spontaneous, it means patient opens before it is a stimulus. Just you gave a stimulus, so he is on his spontaneous opening it. To sound means you are speaking to the patient opens the eyes. When you talk of pain, it's basically you are giving a pressure, and that pressure is now quantified, that you give a fingertip pressure. Not that somebody comes and pinches the ear, somebody pinches the nose, somebody pinches the supraorbital, not like that. It has to be standardized and quantified. So the recommendation is that your finger should be the one used fingertip stimulus, unless until it is definitely amputated or that is different. The index finger is the usual thing which is used. And if nothing is happening, then you call it none. And they have used in all of them what is known as non-testable. So suppose somebody limb amputated, something like that, or patient is under sedation or something, so you say it is non-testable. Don't say that E1. If you not tested, you say ENT. So similarly for the verbal response and the motor response, this has been done, and always they have added a criteria of NT here. So this is one thing which has, I think, should be incorporated in our day-to-day neurological examination practice. I have given whatever the articles which I am dealing with, I have given them to Dr. Kishore so that it can be distributed to the delegates already. So he can mail you and this. Now coming to the next review. This is, as we are selling the neurological update in this, in today's update also, it is taking a back seat. So it is the same thing in the critical care also. And people have realized that they are not the critical care physicians, they don't examine the neurologically the patients. And there is still yet no recommendation has been there for the critically ill patients, for how to examine neurologically. So in 2010, European Society, they have ESICM constituted an expert panel to recommend how to assess neurologically the patients of ICU. And this is published in 2014, Intensive Care Medicine, in the month of July. And it says that it is mandatory that you must routinely neurological examination of the patients, any ICU patient must be done. And how to do it? What all to be done? So you have got, you know that GCS, sold GCS or 4 score. 4 score is basically your outline for your unresponsiveness, full outline for unresponsiveness. GCS is a score by the Glasgow and 4 score is by the Mayo Clinic. Either of these you can use. Then you look for so you see for the eye response, motor response, verbal response, and also you look for brainstem responses. And don't forget to see the others part, that is the peripheral muscular part also. Because of the fact that ICU is one place where you develop polyneuropathy or myopathy. So these are the how you assess, these are the things that has to be assessed. And how you assess them, what is the protocol for it? We know all about that every day there is something known as sedation arrest. We always withdraw morning the sedation. You know, actually, thank you. So, in the day-to-day, so every day in the morning, as these ICU patients, they are under sedation and that. So you have to. So you have to discontinue the sedation in the morning, and after that, once the sedation effect are weaned off, then you look for the neurological examination. And what all you see, if you find it is normal, it is alright, then you keep on doing the assessment. And what assessment you do, that I have shown you in this slide. Okay, what all assessment you do is this. So you look for any focal signs. If you find any focal signs, this patient is, you should name required any brain imaging. If you find the patient is having seizures or any other common new onset delirium, before you go for any investigations, always look for the secondary causes. As I said in the ICU, the reason for the patient's neurological deterioration most of the time is secondary causes. And the secondary causes are your drug effects, the metabolic causes. That the patient is having associated renal failure, so he may have uremic encephalopathy. The patient is having associated liver failure, he may have hepatic encephalopathy. So rule out all those biochemistry and all those causes. And if you find any focal signs or sudden alterations in the deterioration of the consciousness, in that case, it is mandatory to go for neuroimaging. And if you go by the neuroimaging, the screening is obviously the CT scan of the brain is the initial screening you do. MRI as a first line is not recommended because of its logistic limitations. But these are the indications for MRI, and just to make it simple for you, what are the conditions where MRI should be indicated in a patient who is not doing your examinations? Are these conditions where you have acute neurological deficit, status epilepticus patient, patient who is posterior encephalopathy, osmotic myelinosis, hypoxia ischemic encephalopathy, patient with prolonged hypoglycemia. These are the conditions where you may contemplate for MRI. Another thing is as you know that critical care neuropathy, if you suspect the patient when you are examining the patient peripheral that he has weakness in the muscles or the limbs, otherwise he has got no brainstem function problem or any your cortical problem, in those conditions again look for the secondary causes, metabolic causes, and if you rule them out, you may have to go for nerve conduction studies or EMG. So this is how you should evaluate and examine a patient of critically ill for neurological examinations. Now next comes what to monitor these patients in the neuromonitoring, and what is the latest in it. Again, this how it happens that this year only in this 2014 we have got a consensus statement for how to monitor the patients for neurologically. So as it says, as I again say, the aim and the objective of this is to take care of prevent secondary cerebral insults. So aim of monitoring is, as far as ICU is concerned, not only just to identify any disease or that, most important is to prevent any cerebral insults. And what is the best neuromonitor? Till date, no history for it. It is just like it is a nation. It is a journey. We still don't know what is the best thing for us. But the certain strong recommendations which have come in this, your recommendations by this ESICM, which says that you bedside assessment for GCS, routine withdrawal of morning sedations, and most important, invasive hemodynamic monitoring is required to maintain adequate cerebral perfusion pressure, as you have discussed in the morning in your hemodynamic monitoring update. And among this, the most important remains is your ICP and your cerebral perfusion pressure. And majority of the studies are done in traumatic brain injury patient, which has been further extrapolated to spontaneous your subarachnoid hemorrhage and aneurysm bleed and other patients also. And among these, if you see that ICP is the gold standard. The single most thing if you have to monitor in this patient, it is the intracranial pressure. And all other monitoring your data has to be interpreted in the light of intracranial pressure. So if you have a normal intracranial pressure, it's fine. Then you look for other things. But if your intracranial pressure is high, that takes the priority as far as the management goes. Okay. So all of the intracranial monitoring data must be interpreted on the context of ICP. So this is the most important recommendation. So your ICP monitoring becomes the primary, the mandatory thing. Other thing which you can monitor is your cerebral blood flow, your jugular venous oxygen saturation. If you have all other activities available, you can use even cerebral microdialysis also. But all these recommendation for all of them may be strong, but evidences are weak because not much literatures are available. So only literature which is available is for ICP and CPP, and that becomes the gold standard. And what is now come up is what is known as an integrated multimodal monitoring, where you put a single catheter inside the brain. Through that you measure the ICP, you measure the perfusion pressures, you can take the CSF fluid, you can analyze it, you can do the microdialysis, you can do the measure the lactate and pyruvate, everything. So this is a multimodal catheter which has come, and this is the something like multimodal monitor which will be there, which will give you all these informations. And as it says that fools collects the data and the wise interprets it. So data can be there, lots of them. You only have to interpret it in the light of, always remember, in the ICP. There is a recent publication in January 2015 where multimodal monitoring has been used in the traumatic brain injury patient, and as it expected, because majority of this time when these type of studies come in the monitor everything, they are so many time industry driven, and so they have shown that it has some your outcome benefit. But till date there is no recommendation for multimodal monitoring. You have to wait for the time still proper recommendations and your gazettes will be available and then they will come to us for selling them. Now coming to the traumatic intracranial hypertension, this is a review which has been published in NAGM, a very excellent review. I feel everybody should go through it. So it concisely deals with how to manage the intracranial hypertension in the ICU. In the context of that, as you know, all of you know that if the normal values is around 10 to 15 and it increases, keeps on increasing, anything more than 20, you have to consider that you have to interfere. So what are the main causes which have been found to cause increase in the intracranial hypertension? These are all causes basically increase in the cerebral edema, and there is a long list of them. And the topmost list, which are most common conditions, are your traumatic brain injury and subarachnoid hemorrhage, which can be because of any cause. So how to manage them and how to monitor it? So they have suggested an algorithmic approach. In the step 1, you look for ICP monitor and check calibrate, you are sure the ICP is raised. Suppose you don't have ICP monitor, which is quite common, lot places don't have it, even our place also you don't have ICP monitor. So the best thing remains the check the pupils. Okay, so if you are checking the pupils, that is and the poor man's, you can say the ICP. Any alteration in the sign, sudden alteration, you try to find out and go for imaging immediately. If required, you go for intervention. If the person goes into herniation or something, then you may have to go for surgery. So first step is check the pupils are definite or you have ICP. Then once you have found the ICP is raised or pupils are dilated, rules out the secondary causes of it. And the secondary causes can be anything, the vasodilated like fever, seizure, hypoxia, hypotension, all these things, if it is there, you have to look for it. Then increased venous pressure. That is a decrease in the drainage of the brain. As it happens, the simple, if your patient is being nursed like this, it happens so many times in the ICU. patient is lying flat and his head is turned to one side, isn't it? So the patient is hypotensive, so all this circulation is blocked, patient gets a cerebral edema. You have not noticed it. You have tied maybe the tracheostomy, when you have secured it, the tie you have tied is tied very tightly. Your neck veins are congested, isn't it? So all these things you rule out. Your patient is having high PEEP. Your airway pressure is very high. He is coughing. So all those things will cause increase in your ICP. So you must rule out all these secondary causes. Simple bladder distension. You know it happens. Suddenly you find a patient find a stroke patient, other thing, you have taken out the catheter and put the patient on EMC. After 4 hours, 5 hours, suddenly find the patient is sweating, his heart rate has gone up, everything is fine. Sister put the patient on ventilator also, that he is deteriorated. And actually what has happened, that he has got a bladder retention. Isn't it? This is a very common thing. What it means is that you must look out all these things. So step 2 is very important, rather than blindly going for treatment. And then comes the step 3, where you have to go for the treatment. And this treatment has been described in a step ladder form. So from the simple to the complex, with the evidences and the risks for each and everything. You go ahead with the treatment. So start with the intubation, to increasing sedation, to the CSF drainage, to monitor, depending upon the individualized thing what is required. Now patient has a renal failure, he is not passing urine. You don't contemplate to give him a mannitol or hyperosmolar therapy, isn't it? So you have to individualize it in this step ladder fashion, and knowing at the same time what are the risks involved for each one of your interventions. And that is how you have to plan out the management for your ICP. Now coming to the ischemic stroke, which is one of the commonest thing, which we are associated with the management. So in this year again we have an ICU guideline and overview for ischemic stroke management, and it is, as you know, commonly 85% of our patients are having ischemic stroke. And commonly one of the commonest cause of ischemic stroke is cardioembolic. It is involving around 30% of the patients. And this is again the indications for intensive care unit admission following acute ischemic stroke. So this is a big recommendations. What is important is that you should remember that any person having compromised airways, seizure, arrhythmias, large MCS stroke, hemodynamic instability, all the post-thrombolysis and post-op patients like after hemicraniectomy or they need a multi-organ failure, they all should be managed in the ICU. And this is again the management which has been suggested. What it means is that you maintain this airway oxygenation, ventilation. Tracheostomy is considered after 7 days of ventilation, and up to 15 to 40% of the patient of major stroke, they ultimately land up in tracheostomy. Hemodynamic fluid management, usually 80% of the patients they are hypertensive. As you know, it is called secondary hypertension, which the body's response to maintain the CPP. The target blood pressure till date we don't have any guideline for it. There are lots of studies which are going on. Till date we don't know what exactly is the correct pressures. We have recommendation as far as thrombolysis is concerned. If you are planning for a thrombolysis, when you are giving a patient RTPA, in that case you decrease the pressure to less than 180 by 110. About that there is recommendation. As far as what should be the target blood pressure, there is no recommendation. So this is what is said, that you can accept a BP up to 220 by 120. This is for ischemic stroke we are discussing. And among the agents to be used, the agents are your nicardipine and the levetiraol, they are the agents to be used. Nifedipine is not to be used because it causes tachycardia and it is one more hemodynamic instability and arrhythmias. Among the anticoagulations and antiplatelet therapy, so if the patient has not undergone thrombolysis and is not a candidate for thrombolysis, the first drug to be given is aspirin, as it in your ACS also. There is something similar it is. So you give aspirin to them and start them on DVT prophylaxis, because of you expect them to be bedridden for longer time. When they are major stroke, they take time to mobilize, and up to 10% of them have developed pulmonary embolism later. What are the complications? Sometimes two complications can happen. One is cerebral edema, or there can be hemorrhagic conversion of the infarct, ischemic infarct. Or if you are given a thrombolysis, up to 6% of patients they undergo hemorrhagic conversion. We all know it. So if you look for the clinical deterioration, sudden clinical deterioration, and if you find there is an indication of clinical sudden deterioration and hemorrhage or cerebral edema, this patient must be taken for hemicraniectomy. And these are the indications for hemicraniectomy nowadays. The malignant MCA or edematous cerebral acute ischemic stroke, pupillary asymmetry, progression of edema, and a large study has been published which validates that this is an outcome benefit intervention. So this study, which has been published, known as Destiny 2 study, done in patients more than 60 years. We already had evidence of patients of young age where hemicraniectomy is useful, and that time it was done with the idea because in the brain of a young patient can't expand much because there is not much of cerebral atrophy, and it was done at that time Destiny 1 study, and it showed there is improvement in the outcome. That study was in 2009, but we have no data about the old age. And this data, which has come in 2014 July issue of NEJM, where they have studied 112 patients with unilateral infarction with multicentral trial, German trial. So they found if you do hemicraniectomy in this patient, your difference of mortality is around 20% between the person where you have not done and where you have done it. So 38 plus 18%, that is the difference in the primary outcome survival. And if you go by the long-term benefit, the persons who underwent craniotomy, they have a better quality of life. If you go by the Rankin scale is used to evaluate the patient's quality of life. How it has been, like your patients, whether they are dependent, independent, whether they need constant assistance, whether they are vegetative, that way. Higher the Rankin scale, the patients, the worse is the outcome. I mean the quality of life. So if you find that this in the group where the hemicraniectomy has been done, so your patients with the high Rankin scale is less compared to the patients who has not undergone hemicraniectomy. Now coming to the intracerebral hemorrhage, the hemorrhagic stroke, post-thrombolysis bleed, and your vasospasm after post your subarachnoid hemorrhage or aneurysm clipping. Organization, again they have a recommendations. This World Stroke Organization recommendation for 2014 has come. Now if your patient has a hemorrhage, now it is one condition, the chance between ischemic stroke and hemorrhagic stroke, the person of hemorrhagic stroke has more chances of deterioration and complications as compared to ischemic stroke. So it is recommended that if the patient is having hemorrhagic stroke, they always have to be monitored in a stroke unit or in a ICU, because their chance of deterioration over next 24-72 hours much more than a patient who is having ischemic stroke. There is no guideline to suggest about the steroid use or your anti-epileptic to be used as a prophylactically. If the person shows signs of conversion, then only you should go for anti-epileptic. And factor 7, recommended factor 7, that is your Novo 7 has got no role as far as intracranial hemorrhage or spontaneous bleed is concerned. The surgical intervention has to be done only if it is indicated. Just because it is small hemorrhage, you go for it, and that will not going to improve the outcome in the patients. As far as blood pressure is concerned, here we have found that if you decrease the blood pressure to less than 140 systolic, the chances of increasing your size of the bleed is less, and so it is recommended that you decrease the blood pressure. Though what is the optimum pressure for the patient, still it is not clear. Now this comes to the other group, that is symptomatic intracerebral hemorrhage in acute ischemic stroke patient, that is after thrombolysis. You have given them a RTPA, and as I say, up to 6 to 7% of these patients they undergo massive hemorrhage. So if you get this hemorrhage, how to treat that? So you have to classify. So there is no data recommendations till now available. Whatever it is said that the way the person, if they are on anticoagulant and if they get a bleed, you should treat it that way. But there is a difference in these two group of patients. Now these patients, if the patient is on warfarin and he gets a bleed, he is coming to with a bleed and you immediately start the treatment. Whereas here the person is already having a stroke, you have given the drug, and after 6 hours, maybe 1 hour, 2 hours, 3 hours, then you detect the person deteriorates and is bleed. So there are two different subgroups of patients, and so chances of worsening of condition is much more in this type of patients. So that is why you have to have a recommendation and interventions. And it says that the Stroke Association, American Stroke Association recommend that if you find any person has a bleed post thrombolysis stroke patients, you give them at least 10 units of cryoprecipitate is the choice, because you want to give them a proper coagulation factors with platelets. If you have access to triazolone, that is epsilon aminocaproic acid, you give it. And if it is very significant bleed, you should go for, may have to go for surgical intervention with all the covers of blood products. Because if the patient has post RTPA, you just want to do surgical, it may further cause your problem with the hemostasis. But if it is as a severe surgery, brain salvage surgery, you may have to go it. Now this is as far as the subarachnoid hemorrhage refractory vasospasm, which is one of the things that happens so many times after clipping and the coiling of your cerebral aneurysms, which you see so many times, which can happen up to 2 weeks to maybe up to sometime, a delayed one can happen up to 3 weeks also. So how to do it? Up to 30% of the patient is happened. Diagnosis is basically you contemplate mainly by transcranial Doppler is the best monitor. If you see when you are doing transcranial Doppler, you find there is increase in the velocity. That means it is a vasospasm. Your investigation of choice is angiography. And the treatment, all of you know, it is classically the AAA therapy, though there are controversies in it, and not all ICU patients will be fit for AAA therapy if you have associated disorders like cardiac problem, renal problem and those things. The drug which is nowadays coming up and recommended is milrinone infusion in all these patients because of its vasodilator action. It causes vasodilatation at the cerebral vasodilator cell. But once you are giving milrinone, it may happen patient gets hypotension. So may have to support the hypotension with non-adrenaline or adrenaline depending upon the protocol, so they maintain a adequate cerebral perfusion pressure. Other thing which has been used interventional therapies are intra-arterial nimodipine, angioplasty and partial aortic obstruction. These are the things which are still not validated, but these are the things which are in there, which have been used. People have been used in magnesium also, but recently in NEGM paper has come which has shown there is no role of magnesium, and so this is no longer used. So now coming to another problem, that is anesthetic drugs in status epilepticus. This is another paper which has come this year, 2014 neurology. As you know, the status epilepticus patients, they come to our ICU, and once we fail with the armamentarium of all the kinds of anticonvulsants, we ultimately induce them with your anesthetic agents like thiopentone, propofol and sometimes inhalation anesthetic agents. So this is a 6 years cohort retrospective analysis of the data of those patients in 2005 and 2011 who has undergone status epilepticus, who has been subjected to your anesthetic agent for control of status epilepticus. And it has been found that these patients are more prone to infections if you go for them. And so it is a suggestion that it will be found their outcome and otherwise it will be worsened. So one should be careful while using anesthetic agents. But there is, this study is there, so I am just quoting it, but there is lots of question is there. and this is the editorial which has come with this study. There is lots of selection bias, no fixed regime, no etiology based classification. So it raises concerns, but too early for conclusions. Definitely the person who is having status epilepticus is very serious, and that too is not getting controlled by normal medicine is very serious. It is not that you are using anesthetic agent as a first line of drug. So already these patients are so critical, so serious, so obviously they have more chance of infection and mortality. So we should not take it at the face value, but since it is an update and this study has come this year, so this is something to concern, so we must, so I have mentioned it. Now coming to one concept which was this study was even mentioned by Dr. Panja also in the morning. So this is a recommendation in 2010 ASA guideline of AHA guideline for ACLS, that is any person who underwent cardiac arrest and now has return of spontaneous circulation should be subjected to your hypothermia at the earliest. And in fact they have gone to the extent that if you take a long transport time, you do it even during the transport also. You know, so this is how the extension of that, and this is the recommendations. And the recommended temperature is 30, which they have recommended 32 to 34 degrees Celsius. Now these were done on the basis of 3 to 5 randomized trials which are evidence available. So what they have done now, but this is the original study, this has come, and the first trial came in 2001 actually. Now this is the trial which was published in the December of 2013. The targeted temperature management at 33 degrees Celsius versus 36 after cardiac arrest. Now this contains 950 patients. This is a study of the Scandinavian group, Finnish group. It is a multi-center prospective trial where none of the authors have any conflict of interest as far as your hypothermic devices are concerned. Why I am telling you, I am come to that because there is a recent editorial on it. That was good one last slide. So when they studied this patient, they have followed it up to 180 days, that is 6 months. And they found that in both the groups, when though they have achieved 33 target of 33 and 36, they don't find any difference in the from discharge point of view or from your CPC, that is cerebral performance category point of view. There is no difference in the neurological outcome. So whether to go for hypothermia or not, it is a questionable. But definitely, as we know from our experience, hypothermia is not to be allowed in any patients of neurological disorder. About that there is no question. But should we go for hypothermia or not? That is a big question. And in the recent this JAMA, we have on basis of this, there is this editorial which says that in this study they have about 950 patients, whereas the earlier 5 randomized trial which had been done on that basis, this recommendation has been made, they have only seen less than 500 patients. And the most important thing is that out of that 3 authors, the first author of all the randomized trials, they have a conflict of interest with this company which are making these hypothermia equipments. So that is why it is still in doubt whether to use it or not to use it. So it recommends that therapeutic hypothermia for the patients for the neurological outcome to be at present should be available, whatever the best evidence available, it should be taken with some pinch of salt. So what are the future directions as far as neurological ICU concerned? Intra-arterial thrombectomy is under evaluation for ischemic stroke. Till date, no recommendations. Though we have a recent study which is come, which is a MR clean study from the Norwegian group, which shows there is some outcome benefit, but still no recommendation. Just like PCI, we have a recommendation for ACS, intra-arterial thrombectomy, no recommendation. ATTEST-2 trial, it is a trial for your appropriate blood pressure for your cerebral hemorrhage. Till date, it is in the recruitment stage. Maybe by in the next year they will come out with recommendation, because this is a very well planned study. They are doing it in a randomized way, prospective trial, and if this may be able to tell us what is the proper blood pressure. We don't know exactly till date. Somebody say less than 140 for hemorrhage, 220 by 120 for ischemic stroke. Till date, no clear-cut guideline or recommendation available. So attest to holds that way. Maybe that once it comes out, it may tell us something. What is the recommended blood pressure? And multimodal monitoring for neurocritical care is at its infancy, and it may be incorporated as the standard of care maybe in the future. Thank you.
Thank you, Debashis. That was an excellent exposition of what neurocritical care at a crossroads is today, and obviously paid much more emphasis upon attention to detail in managing patients of needing neurocritical care. I've got one small question to ask. You talked about tracheostomy in patients of having stroke in passing. So in general, neuro patients tend to have early tracheostomy. But I need to know from your horse's mouth as to when we mean early tracheostomy, how early do you mean that?
See, the point is that, I mean, there is nothing like early tracheostomy for any patients. Okay? The patient has to be stabilized. And when you are doing any intervention, this is an elective thing. It is not that you are doing for securing the emergency airway. Okay, so whenever you are doing a tracheostomy in ICU, you have to contemplate always. It has to be taken into account all the safety, everything in the your consideration, safety consideration. And as I say, always these patients who are in the ICU have come with neurological disorders. We know that up to maybe 4 or 5 days, maybe up to 7 days, there is increased chances of raised ICP. Especially the patient like your intracranial hemorrhage. All those things, we don't know exactly their status. So if you at that time, I try to intervene, may happen that I subject them to hypoxia. When you are extending the head, extend the neck for positioning, you are causing again increase in ICP. So I don't think you should contemplate not earlier than 7 to 10 days.
So 48 hours is not the norm?
No. Next, I've said it in the recommendation, they have said at least 7 to 10 days, not
that's
you should not do it. And because it is not gaining anything, you are doing it for the purpose that you expect that this patient is going to have prolonged ventilation, so that is why I am doing it.
Thank you. Any questions from the floor? Right, if there are no questions from the floor, we end this session, and thank you, Dr. Debashis, for your.